Okay, so now that we know a bit about pain and nociception, we're going to talk about a couple of related phenomena that are interesting. So the first is how local anesthetics work. So local anesthetics are lidocaine or novocaine. You get injected with that at the doctor's office, or maybe if you cut yourself and needed stitches, or perhaps you needed to have a mole removed or something like that. The provider, your clinician, would have used lidocaine most likely, or another local anesthetic. That's what we call things that numb you up and relieve pain just locally in a defined area, as opposed to a general anesthetic. That would be like we're putting you to sleep for the operating room. You're going to be unconscious. So a local anesthetic is just for a local, just a small regional area. So these chemicals are really interesting. So what these compounds do is that they get injected into the area and they move into, that doesn't show up. Let's try bright red. They move into the cell and then they lodge themselves inside the sodium channel, inside the voltage gated sodium channel that normally will open in order to initiate an action potential once a neuron reaches threshold. So what's so cool about how lidocaine works is it actually blocks those sodium channels from opening. So if sodium can't rush in, you don't get a depolarization, you don't get an action potential. So that's how lidocaine works. It's also another opportunity to talk about the nerve fiber diameter, right? So the axon diameters for pain fibers are those A delta and C fibers, which are the smallest and least myelinated. So they are the easiest to get numb. So you may have, if you receive lidocaine, they may have said to you, now you may still feel touching, but you shouldn't feel pain. And that's because these guys are small. It's really easy, it's easier to numb the nociceptors than it is to numb the mechanoreceptors that have those bigger, fatter, better myelinated axons. Isn't that cool? All right, physiology in action. All right, what about when you bang your shin and then you like rub it or you hold it really tight, or you stub your toe and then you grab it and you hold it? Why does that help with the perception of pain, and is it actually helping? So it is actually helping, and there are a couple of hypothesized reasons why. It's kind of hard to do experiments to find out for sure. But one of the hypotheses is that because touch uses those faster A beta fibers than the slower pain fibers, which are the A delta and C, you can send more action potentials because each one goes more quickly. You can send more action potentials for touch or pressure than you can for pain. So one idea is that you're just sending so many more signals for touch that it overwhelms the signals for pain because they're just outnumbered. So your brain can only pay attention to so many things at once, so it pays attention to the touch more than it does the pain. There's also this idea that something might be happening to inhibit that synapse of the nociceptor's first order neuron with the second order neuron that's sitting in the dorsal horn of the spinal cord. So there might be something happening where, the touch perception is suppressing pain reception right there at that second order neuron for the pain pathway that's about to go into the lateral spinothalamic tract. This is sometimes called the gate control theory of pain. There's also some hypotheses that it might be more central, that there's something up in the brain happening. We're not exactly sure, but what we do know is that you definitely can decrease how much something hurts by kind of pushing on it or rubbing on it and kind of overriding that pain sensation with those mechanoreceptors. Yes, Oliver had something to say about that. The other thing about pain is the withdrawal reflex. Now, you learned about this before. This is the stepping on a Lego reflex, or as the limb textbook talks about it, you put your hand in your book bag and there's like a sharp pencil point or something, and you quickly pull your hand away. So what's happening here? So we have a painful stimulus. So He's sitting on my keyboard, so let's see if I can make this work. Okay, so you have a painful stimulus that's coming in on your nociceptor. So painful stimulus coming up, thank you for the kisses, coming up on your nociceptor, entering the dorsal horn of the spinal cord. Now, when we talked about the lateral spinal thalamic tract and the pain pathway, we talked about how you're going to synapse with a second order neuron right here, and then it's going to decussate, and then its axons are going to go up through the lateral column. That is going to happen, right? So you are going to have that synapse. But what this diagram is showing you is that you're also having other synapses. So that axon terminal is also synapsing with other neurons. So the first one I want to draw your attention to, he's being really in the way. I can't find my cursor. Where's my cursor? Okay. First one I want to draw your attention to is this interneuron here. So we're going to synapse on that interneuron, which is going to signal a motor neuron to contract your flexor muscle. So the flexor muscle is almost always going to be the one that pulls you away from something. So this is flexion, right? Getting into kind of this protective thing, that's flexion. This is extension, right? Open wide. Flexion is closed in. So it's a very kind of protective, think like an armadillo. You're like, right? You're closing in that part of your body that's just been exposed to a painful stimulus. So you're going to contract that flexor muscle right there to pull your body away from the stimulus. Now, what you're also going to do, is red, is you're also going to synapse with an inhibitory interneuron. And that one is going to tell the motor neuron for the antagonistic muscle, the muscle that would fight you, to relax. So it's going to say, hey, in this case, these are supposed to be your hamstring, or excuse me, your quads. Hey, relax, so that you're not fighting the flexors that we're using to kind of pull away. So kind of cool to revisit the withdrawal reflex now that you know a little bit more about nociception. And now you probably understand here now where it says A delta, right? That those are those A delta fibers that are carrying that stimulus. So remember, in addition to these synapses with the interneurons that result in this withdrawal reflex, this flexion reflex, you also will then synapse with a second order neuron in that dorsal horn that's going to decussate and send its axons up the lateral spinal thalamic tract so that you are also get conscious awareness of that sensation. Okay, so that's a withdrawal reflex. The other thing I want to talk about is referred pain. So far in talking about nociception, we've talked about pain that comes from the somatic parts of the body, the skin, your muscles, your joints. But it turns out that our inner organs also have the ability to perceive painful or noxious stimuli, but they're kind of vague and diffuse and not super good about it. The other thing that sometimes happens, so it can be very difficult to pinpoint or localize. The other thing that is interesting about visceral pain is that it comes into the spinal cord alongside somatic pain. So here they're showing you somatic input, right, from, the hand is coming in, right, and you've got your dorsal root ganglion and it's coming into the dorsal horn. Here's your stomach. Now, visceral sensory is weird. So look, we've got a celiac plexus, we have a sympathetic chain. It's weird. We'll get to it later in the course. But look, it comes in and it also has its cell body in the dorsal root ganglion. And then it also comes in to the dorsal horn. In fact, it might even synapse on that same neuron, that same second order neuron in the dorsal horn that then is going to decussate and send up through the lateral spinal thalamic tract as the somatic one. So this is called the convergence theory, where these two different types of input end up signaling the same neuron in the dorsal horn. And then so of course when it arrives in your brain doesn't know which one it came from, right? It can't tell. So sometimes when you have pain coming from an organ, it actually feels like pain coming from a different part in your body. So that's what's called referred pain. So pain from certain organs can be mistaken as pain from other parts of the body. So this is the diagram from the limb textbook of common locations of what are called referred pain. So you can see if you're having pain, excuse me, Oliver, if you're having pain from your appendix, let's say you have some appendicitis, even though your appendix is located down here, you could feel the pain anywhere around here because those nerve endings are entering the spinal cord and potentially synapsing with the same second order neurons as somatic sensory neurons from that region of your body. I want to point out to where am I? Down there. Okay, the heart. Right? So if you've ever heard that sometimes when somebody is having a heart attack, they might feel pain radiating down their arm, that is referred pain. There's also a really interesting one that isn't kind of shown here. So they talk about liver and gallbladder kind of going to this right side of the back, kind of under your shoulder blade, which it definitely can, but it also can go to your right shoulder area. So this is fascinating because the liver and gallbladder are located right underneath the right diaphragm. So they're kind of sitting right underneath the right diaphragm. This is mirrored, so I guess right diaphragm. And so sometimes if something is going on with your liver or gallbladder, it irritates that right diaphragm. So there have been people, for example, with gallstones who went to the doctor complaining of shoulder pain, of right shoulder pain. Mirrored right shoulder pain. And so sometimes then they got referred to an orthopedist and got an MRI to look for a rotator cuff tear, but all along it was actually gallstones. Interestingly, also after abdominal surgeries, sometimes for getting your gallbladder removed, sometimes for other things. So this happened to me after I had a C-section. Air gets in your abdominal cavity because like it's open, and when you sit up, that air kind of comes up, it floats up and it sits underneath your diaphragm, and it tends to be very irritating. Your diaphragm doesn't like it, and so your diaphragm sends pain signals, which then you interpret as shoulder pain. I had the worst shoulder pain for about the first 24 hours after my C-section. So after any type of abdominal surgery, even and sometimes especially laparoscopic surgery, that is very common to have shoulder pain due to irritation of the diaphragm. So anyone who's going to work in healthcare and medical care needs to be really aware of this phenomenon of referred pain, because otherwise you can absolutely bark up the wrong tree. Oh, the other thing that's not on here is the location of referred pain for the uterus, and it's actually in the small of the back. So a lot of people, if they have bad period cramps, sometimes they'll feel it in the small of their back. Or if you've ever heard a woman talk about having back labor, where the pain of her labor for childbirth was in her back, that is because that is a location of referred pain for the uterus. Excuse me, Oliver. Okay, so that's referred pain. Lastly, I want to touch on neuropathic pain. This is not in the textbook, but it's so important clinically, I couldn't leave it out. So neuropathic pain is pain due to a problem with the nerves. So it might be the individual neurons, it could be the nerve endings, it could be something in the spinal cord, but something in the nervous system is damaged or injured or inflamed, and it causes pain. There's lots of different types of neuropathy. Sometimes it causes pain, which is often a shooting or a burning type pain. Sometimes as it progresses or gets worse, then you actually get deficits in the nerve function, so you might have numbness. And if it also affects the motor nerves, you can even develop weakness of the area supplied by those nerves. So some of the most common causes that we see of neuropathic pain, and there's different types, absolutely. High alcohol use actually can damage your nerve endings. So a high alcohol consumption can cause neuropathy. Diabetes is famous for causing neuropathy. Excuse you. Trigeminal neuralgia, which we already talked about when we learned about the cranial nerves, and we learned about that pain due to some irritation of the trigeminal nerve, sometimes due to pressure from an adjacent blood vessel. And then shingles is another one. Shingles is a rash accompanied by pain along a specific dermatome caused by reactivation of the chickenpox virus. So any of us who had chickenpox as a kid, guess what? You have the chickenpox virus living in your body. In fact, it lives in the dorsal root ganglia kind of just hangs out forever and can reactivate, travel out along your spinal nerve, and cause a rash and pain in that dermatome that represent where it came from. So anyway, so that's shingles. So depending on how severe it is, right, you might just have tingling or burning, but you might also have numbness, or you could even have some motor deficits as well. So that's neuropathic pain. So in summary, kind of all these different things that can happen with pain, we learned that local anesthetics work by blocking the sodium channels so that you can't make an action potential. Sodium can't rush in and depolarize the axon. We also learned that pressure on or rubbing of an injured area can help override the pain signals, perhaps because they're much faster, so you can send more of them in a defined period of time, or perhaps due to that gate control theory of pain, maybe it's inhibiting things at the level of a second order neuron at the spinal cord. We also reviewed the withdrawal reflex. So in response to a painful stimulus, not only is that synapse in the going to synapse in the dorsal horn to then go up the lateral spinal thalamic tract, but you're also going to synapse with some interneurons in the spinal cord. One is going to tell the motor neuron for the flexor to contract that muscle. The other one is going to tell the motor neuron for the extensor to relax that muscle so that you can pull that part of your body away. Then we talked about referred pain, so the fact that a lot of the pain sensors coming from our viscera or inner organs, our inner guts, enter the spinal cord at the same place as somatic nerve signals, which are much more specific, and our brain can confuse the two. So you can have shoulder pain from a gallbladder problem, for example. And then lastly, we talked about neuropathic pain, which is pain and sometimes other nerve symptoms like numbness or motor weakness that are due to damage, inflammation, or injury of the nerves. So we have one more section in lecture 1212E, proprioception. That is next. See you then.